right. Hello. If you're in the viewer section, can you type anything in the chat so I can see if you guys can see us? I don't know. Anybody can see me? Let's see who's here. I don't know if I can see anybody that's here. It just says there's a number of viewers, but it doesn't say. Just got one comment. Okay.
That's mine.
Yep. Can you see and hear me?
Yes, we got confirmation they can see us.
Oh, okay. If you guys are watching this and you can see and hear me, can you go to the discussion tab and just type in there? Because I want to make sure that as you guys have questions that I'm able to see them. And this is kind of a new platform, at least for the four of us on this call. So I'm wondering if it's a new platform for many of us that are joining. I think one of you guys were making a joke about how many advanced degrees are on this call, and yet we're trying to still figure out this platform. But yeah, so if you guys can put in the discussion, typing, is it one of us that's up here?
Nope.
Nope. Okay. All right. Well, I want to welcome all of you. Oh, it says show 5 comments. Oh, there we go. Now I can see you guys. It was a me issue. Yay. How are you guys? Hi, Nora. Hi, Angela. Hi, Allie, Kelly. Thank you so much for being here. Kelly says that she can see us. I didn't see that before. So we have to keep refreshing the comments. That's good to know. Okay. Hi, everybody. Thank you so much for joining. We're going to just start a little bit of me just giving a thanks to you, all of you, for being here. We're going to start the actual discussion at 2:15 or 5:15, depending on where you are in the country. So that way it gives some time for people who are probably rushing to get on. There's never a good time to meet everybody's time schedule. So we're going to start the official, Q&A with the presenters on the panel in just 8 minutes. But I wanted just to take a couple of minutes to thank everybody for being here and for celebrating National Women Physicians Day. Last night, I was up until 1 in the morning. If you follow me on social media, you will know that because I was actively posting. I felt like I was, it was like, the night before Christmas or going to Disneyland or anything that's super exciting the next day. And what was different this year than before is that when myself and Dr. Kim Jackson, when we were on the phone, and now 7 years ago, we were really frustrated and we were be known as physicians. Our patients are not realizing that we're physicians. Our male colleagues, administration are treating us poorly. There's discriminatory practices, pay gap, all these things. And we're like, it really just starts with us recognizing ourselves, and I remember I was on vacation. I was in New Jersey at my brother-in-law's house and we're talking and, I was like, we should create a holiday, and it's like, well, how do you create a holiday? And none of us knew. So we Googled it. And apparently you could apply to be a holiday, but we didn't have time for that. So I said, hey, listen, on Facebook, when it is Dog Day or it is Sibling Day or whatever, how do we know? Well, someone else posts and then you have this thought that if you don't post, you're going to hurt your dog's feelings. And so that you post your dog, right? And Dog Day is super popular, right? And so everybody wants to show off their dogs. And every other day is super popular. So I'm just making fun of the Dog Day, but it just goes to show who gets to decide what day is what day. We all get to decide as a community. So we marked February 3rd as National Women Physicians Day with the hope that we would make a change, a small dent in women inequity in medicine. And then it's just crazy to me to think that 7 years later, I'm sitting with the top recruiters and health systems in this country talking about the same thing that Dr. Kim Jackson and I thought was just a dream 7 years ago, to have this discussion and to be really frank about the experiences that we face as women physicians. So I just want to thank you guys for being here. This is a very special year for me to be celebrating with all of you. And I want to thank you as a panelist for being here And for the physicians on the panel, I want to say National and Happy and WPD. And I want to thank you for being brave and addressing these really hard topics that are unfortunately too common, and how your institution deals with them. So if anybody has any questions for me, for anybody on the panel as they're discussing, I want you to put it in the discussion so we can address them. There's over 300 people that will be on this call. So please ask your questions. If I see repetitive questions, like, I'll try to lump them in one or, summarize them. But I really want to make sure everybody's questions are answered. So that way, when you're meeting all of the potential employers, it can spark some thoughts of questions that maybe you want to ask, and find the best situation for you. Okay. So I see that the chat has kind of stopped. So if anybody else has any questions, let us know. Otherwise, we're going to start in 4 minutes. And I think that if you guys have any questions right now about how this is going to be run, let me know in the discussion. Otherwise, I'm talking to myself.
Comfortable? Do they want to put in the discussion like either their specialty or just so we have a sense of who we're talking to? Like, I know your emergency medicine, your internal medicine. Leah and I probably are interested in every. Well, you're focused on primary care also. I'm interested in everyone and everything, but maybe if people want to share a little bit about themselves.
Yeah. If you feel brave, tell us your specialty. Let us know. I don't know. I think the people who, let's see what the most popular specialty is. Let's see. Oh, awesome. Dr. Thompson, I see that you dropped it in there. Internal medicine, preventative medicine, lifestyle medicine, and hypertension specialist. I didn't even know that was a thing, a hypertension specialist. That's amazing.
Very
All right. Let's see. OBGYN, yes. Pediatric nephrology, internal medicine. Gosh, where are my ER girls at?
I think I'm winning so far. Granted, we'll take all specialties, but I think primary care is winning so far.
Definitely. Well, I mean, primary care always wins. That's what in my CT surgery. Look at you. So it seems like the only people to talk to are recruiters, not other physicians. Is that what we're supposed to be in the chat? Yeah. So in the chats, you guys can talk to each other, but this will be, us kind of collaborating, figuring out questions we want to ask. So these are just 3 employers that are represented. I think there's 14 or more. I can't remember exactly how many there are. So then you can go and you can ask your questions. So if you're thinking about relocating, you're unhappy with your job, you just want to see what's out there, you're trying to get competitive offers to find the best, deal for you. Like, this is what today I want you to use is all the things that you see as potential opportunities in the practice that you have. See what's out there. All of the employers that are here today are very aware that we are going to ask them these hard questions about discrimination, about gender inequity. And in fact, this is kind of just the first of hopefully, a yearly thing where maybe I'm hoping that this is successful enough that we can get like a signed manifesto in the future of, practices on, not having, a wage gap, having transparency of pay, parental leave policies that are fair and equal, and all the things that we talk about that really actually brought PMG together, right? So the reason why a lot of us start, in PMG is because we're given this ultimatum between work and parenting, or work and life and our family. And I don't know about you, but I don't know of anyone that would choose work over their family. So this is where we're trying to change the culture of medicine. And it starts with you guys putting in the chat what you want to see change. And here are the employers that can actually help, at least relay those requests if they don't already do them. And then hopefully advocate for better practices, or just know what better practices are out there. Maybe we don't know what some institutions are already doing. and perhaps there are some really good opportunities for us. Oh, 23 employers. Okay, so, and they're all around the country. Don't have a limiting belief that if that person is not in your state, that's not a good opportunity, because I am an example, of moving recently, and there's always opportunity. So we have podiatry and lower extremity orthopedic surgery, internal medicine, ER from Canada. Yes. OBGYN, emergency medicine. See, my girls are showing up. More emergency medicine and critical care, behavioral neurology. That's awesome. And I think I caught up with the chat, right? So it's 2:15. So without further ado, we're going to get into the panelists. And what we're going to do is I'm going to introduce who is on this panel so you know who's talking and who they represent. But if you were following any of my posts or emails, I basically have 3 different scenarios that I'm going to ask these 3 amazing women on this panel about their institutions or their recruiting practices and how they deal with these really common scenarios that we see talked about in PMG, and how they can protect and advocate for these women going through these processes. And I think we've all been in one of these situations. But before I get into those scenarios, I want to introduce today's panelists. So I don't know how it looks like in your screen, but on the bottom left, representing Merritt Hawkins, the Division of AMN Healthcare, is Leah Grant, who is the Division Vice President of Primary Care. Leah Grant is well-versed in the strategic and operational issues inherent in physician recruitment and retention, including financial incentives, advertising, interviewing processes, employment agreements, equity negotiations, and practice establishment. And I don't want to embarrass her, but she's about to be a mom. I don't know. So tell Leah, is this your first child, or how many kids do you have?
It is my first child, so I need everyone to wish me luck. It is a baby girl expected to arrive on April 20th. So all of the mom tips, you can't ever get enough. So feel free to share them.
Actually, I'm gonna help you out on the other side. You guys drop in the chat one thing she does not need to buy, okay? Because I know marketing at Bye Bye Baby and all these places make you think that you need everything. So drop in there what she does not need to buy. My contribution to this conversation is a baby wipe warmer. Do not buy that. So you guys can fight me on that, but put it in the chat. What does she not need to buy? And congratulations to you. We can't wait to celebrate your new baby. I cannot believe it.
Thank you so much.
So happy. Okay. So next person is representing Northwell Health is Judith Heller. On my screen, she is the top right-hand corner. She holds an MBA and an MPH, and she is also the vice president of the Office of Physician Recruitment. She is an experienced program developer and change leader with a demonstrated history in healthcare management. Judith, you are such a trailblazer. Thank you so much for being here.
Thank you for having me, and congratulations, Leah. I have 2 little girls of my own. They're 9 and 10, and you probably need very little to get started. There's probably a lot of things your friends can give you, and that's okay. You don't need to buy everything brand new.
I like how someone said, I purchased the baby wipe warmer. And somebody else said, yeah, my baby loves it. Okay, I'm sorry. I didn't mean to trash the baby wipe warmer. I'll take it back. Leah, do what you want with the baby wipe warmer. But yeah, I think it'll be interesting to see what people actually don't find valuable. It'll be really interesting. So yeah, Judith, thank you so much for being here. And thank you for all the changes that you're making in your organization, and for your dedication to your time to really helping women physicians and helping them get equity and parity.
Thank you.
So, and last and definitely not least is representing Kaiser Permanente is Dr. Naila Thompson. And she is the site director and program director of the internal medicine department. She is one of 2 clinical hypertension specialists in the Kaiser Permanente East Bay region. And she also started a specialty blood pressure clinic at the Oakland Medical Center as a service to all Black and African American patients in the East Bay with poorly controlled hypertension. That is super impressive. Like, I want to cry just reading that. Like, I just so needed.
Thank you. Thank you for having me. And my most important position was not mentioned. I'm mommy to a 19-month-old boss.
Aww.
19 months. That's such a fun time.
Yeah, he's crazy.
And what a cool little boy to be. It's a boy, right? You said? Yeah. What a cool little boy to grow up and to see that, like, you're literally single-handedly innovating new processes to really address. We all discuss and say that there's disparities in healthcare, but to see actual programs that address it is just really beautiful. So thank you for being an example to all of us.
Thank you.
I'm sure there's so many people who probably want to start some type of specialty clinic like that. So not that I'm offering your expertise, but reach out to me. Okay, so how it's going to work is I have 3 scenarios. I'm going to introduce one scenario, and basically we're going to kind of round robin, and we're going to talk about it, how all of their institutions or recruiting agencies, how they have seen this dealt in their institutions. So this is not about like painting a kumbaya picture. There's no perfect institution, but we're going to have a real discussion of like, what are the wins at these institutions and what are the things that are, what we could work on. And just like any relationship, there's no relationship that's 100%. So with that said, first scenario. Okay. So Dr. Jane Doe, she is in every scenario here. She's a beloved physician at your institution. She is pregnant in her 2nd trimester and just started to tell her colleagues. Her colleagues have varying responses from congratulations, just as we saw here on the panel, to, oh gosh, how much time are you really going to take off? And that's including her medical director who asked that. She is pressured to take the minimum time off that she can, and is told that her bonus will be affected and she needs to make up RVUs and or shifts. So because she put on such a burden, because her absence put on a burden with her colleagues. So these are real life situations that I've seen posted hundreds of times on PMG. And we face it. And so this goes unreported. I mean, the reason why people are talking about it in PMG is because they're scared. They're scared of retaliation. And so here are some questions that we would like to know. So the first one, and I'm going to have everybody answer this one, is what is your maternity or parental leave policy at your institution? And how does it incorporate the protection of income for your prospective physicians who may apply for open positions at your institution? So we'll just go with Dr. Thompson first, and then we'll go around.
Okay, great. Thank you. So I start with a disclaimer that I am not an HR professional nor a recruiter. I'm just a physician and a mom who recently went through this. And so I think I would just say that we have a great HR department that can help us through this. The points that I really wanted to make is that I think, we follow kind of state and federal guidelines on the kind of medical leave, but then there is a way to combine other leave with vacation, disability, and working directly with your leaders and your chief. And so for me, I was able to take the leave I needed after I had my son, but also to continue to take bonding time and have time throughout his entire first year with him through that leave. And that was really important to me. Our jobs are protected, our bonuses are not affected. And so you can really enjoy that time with your baby without stressing that your position will be gone when you come back.
Wow, that's really amazing. That was not my experience. So that's really good to know. That sounds like a glorious amount of time off without worrying about, a lot of your protection, And Judith, what have you seen at your institution?
So I would say similar to what Dr. Thompson is describing, but I've been with Northwell for 15 years, and I've definitely seen a change over the 15 years. I've been sitting in this seat for 6 years, and what we're seeing and pushing for more and more is the ability for women to flex up and down. So let's say you're a 1.0, but you come back from maternity leave and you really feel like you want to be a 0.8. You really feel like you only want to work this many days a week, or you really want to shift to a 12-hour day. We're recognizing that if we want to be competitive in the market and we want to be respectful of our female colleagues, we're going to need to adjust to their needs. And if you do that, if you are flexible during that 1 year of bonding, you're going to create loyalty and trust that will last you well beyond those years. And I think that's what as we continue to grow, we continue to identify those ways to connect with women where they are and make Northwell a better place to be.
I mean, thank you for your honesty. I think what I was really worried about in this hosting such an event is someone coming in and be like, no, it's perfect. And you're like, no, actually, our practices weren't perfect. And we had to make it perfect, not only because it's the right thing to do, but also if we want to really not only recruit these women, but also retain them, we're going to have to build that loyalty and love on them, right? During this time in their life where they need to be there for their family.
But we can be honest though. There are some specialties that make it easier than others, right?
Yeah. Like what do you think?
So there are so use anesthesia, right? If you're an anesthesiologist and you decide you want to stay out a little longer, you want to come back like a little less, I feel like it's easier to backfill anesthesia. If you are cancer, internal medicine, and you are the heart and soul of that practice, it is tougher, right? Those are your patients. You are caring for them, and having the strong, I would say, support system in the practice, having the NPs, the PAs that can stretch you are what we need to put in place in order to make this more of a reality.
Mm-hmm.
I would just add that. Can I just add that I am internal medicine, I'm primary care. I have my own patients, and I think nothing is perfect by far. And I hope that is not how my answer came across, but what made it possible for me to adjust my schedule and do what I needed to do. Some moms came back sooner. I needed to work less throughout that first year. And my colleagues, I have a lot of other physician mom colleagues as well who understand that, and so they're willing to help and help cover my patients, and that's kind of the collegiality that is needed for things like this to work.
Yeah, and so say there is a primary care, Judith and Dr. Thompson, say there is a primary care physician that, and usually it is the primary care physicians that feel the brunt of it. They're often overworked. Not and underpaid. I'm not saying anesthesiologists are not. I'm just saying that, I tend to hear that a lot. They're the bulk of our physicians. They're very extremely valuable. Without them, our health systems would be nothing, right? And so how do we protect them where they have that flexibility? Because especially when it's your first baby, well, it doesn't matter. I've had 5 kids and it doesn't matter. Every time it was different. I felt my first time, I had no idea what I needed. And so asking someone to plan ahead is so hard. So what do you envision, or what do you think that's the realistic possible future for both of your institutions of building some safety net situations where say your kid is in the NICU for a long time or whatever it may be, or you just realize you need a little bit longer time to bond. What's that safety net where it's okay, we understand and we're not going to make you come back or stretch you thin to serve all these patients? What's the staffing issue behind the scenes there?
So can I take a shot at that, Dr.? So it's 2 pieces. So in scenario 1, Jane Doe is in her 2nd trimester and feels comfortable sharing in her 2nd trimester. And I'm going to overread into the scenario that she only felt comfortable sharing in her 2nd trimester because for all of the reasons, right, we're discussing afterwards. I think Northwell has 4,500 employed physicians, just under 1,000 in medicine. If we know in advance, we can plan and we can sort of shift people to cross cover exactly what, we were discussing before. And people need to feel comfortable sharing, not when they're 8 weeks pregnant, but if they can share earlier on, then we can plan better. And I think we need to create an environment where people feel comfortable doing that and not oh my God, I need to wear bulky sweaters so that I can hide this until the very last minute, because then it makes it harder to plan.
Yeah, I think there's a lot of reasons why women don't share that they're pregnant. I think part of it is, the fear of, all of the discrimination that you're going to get, not only from your fellow colleagues, but also your patients, right? They have questions and concerns and, things like that sometimes, not all of them. But the other thing too is that, we have a lot of women, the rate of infertility in women physicians is high. I mean, I had to have infertility for all my kids, and I didn't want to say anything until like I was at viability. I was like, wait until they're 28 weeks because you just never know what can happen. And so it's kind of hard to be like, okay, let us know, but on your own terms. And so I think that that's really hard. So do you see a future where maybe there's like a safety net person that's like, hey, we're going to increase staffing, but without alerting the masses that, someone might be pregnant or someone might, because I mean, this goes for, pretend it's not pregnancy. Pretend there's a colleague that ends up having cancer or needing, I mean, I just went through a prophylactic mastectomy. Like I needed to do that. I didn't really want to tell people I was having a prophylactic mastectomy, right? Until I was, I decided later on. So is there like a safety net where someone can just say, hey, I perceive that there's going to be a change in my schedule for a life event, right? And, maybe like have a little bit of, protection, where it's not really known to the group, but knowing that, you're going to have to bulk up a little bit.
I can answer this. So in recruitment, you typically have two different types of recruitment. So you have your permanent physician recruitment, which are going to be your providers that come on site and are there long-term, they're signing contracts and they're part of the organization. And then you also have locums. And so you can also, before you join a group or even after you join a group, ask your group what their stance on locum providers are. So if there is a time that you need to take off maternity leave or an LOA due to a personal issue, you can have a locums provider come in and of course cover for you, and that's all covered by your group. Now, of course, it's asking it on the front end and knowing. And I think to your point earlier, I mean, even with the most recent Merritt-Hawkins survey that we've done in women equality and pay disparity, 76% of women said that they feel as though they do get paid separately or differently than males, no matter the situation and no matter the differences in their lives. And that could be because of maternity leave and they feel like they need to catch up when they return. But I think it's two different concerns. The concern of, gosh, I got to make up my pay when I return. That's something that can probably be covered in a contract security to be sure that you're not needing to make up additional hours and almost be penalized for you taking time off. Now, the separate concern is making sure that job security is there and that your group is going to secure you with a locums provider or some additional support within the group, depending on the size of the group in your absence.
Well, Leah, can I ask you a question? Because you work for a recruitment agency, so you don't work for a health system. So being a woman, and I know I've had multiple conversations with you before, so and I'm not the only woman that's in your life that's a physician. How do you position Merritt-Hawkins, like to screen some of these deals? I mean, I know you guys are not lawyers, not contract lawyers, but how do you screen some of these deals where like, hey, listen, I'm not. Where are the ethical boundaries, if anything, or that maybe you have in place to really protect these women physicians that might be interested? And you're like thinking, hey, they don't have protection for this, or they, or maybe they have a history of high turnover because of X, Y, and Z. Like, where do you ever deal with that, I guess?
Wholeheartedly. An amazing question. So the first thing is education of the recruiters. Any of my recruiters that have contact with any client, no matter what level you are at, you are getting trained to ask those questions. Because discrimination, whether it's gender, whether it's from your background, culture, color, it comes in almost every different form or fashion. So our recruiters are trained to go through a screening process to be able to vet that out. Sometimes it's as simple as exactly what you mentioned, asking, is there a preference of male over female? And then digging in to figure out why. But then also being trained to say, hey, we need a copy of your contract on the front end. So before we even dive into accepting the position, we typically ask for a copy of the contract to see what are the terms and conditions of the contract around work RVU, around leave, around all of those concerns that could come up. And we consult with the client on the front end to make them aware. You'll be very surprised. Some clients are transparent. They're like, hey, I need this. And this is the reason why. And sometimes it's discrimination. And so the team is completely trained to immediately say, sorry, at Merritt-Hawkins, we do take discrimination and disparities very seriously. And we are not able to represent your role if that is something that you would like for us to represent. So we cancel it out before it even becomes a concern, because realistically, we won't ever be able to represent physicians and moms like each of you that are on today's call if we're not doing our due diligence on the front end to vet that out.
I'm so glad that you do that. And because I think our view of recruiters, especially, from the group, this is like kind of like a summary of the posts I see. So this is not like all personal experience. What I see is, well, one, a lot of recruiters almost like not even paying attention to who we are. They don't know anything about us. It's a lot of cold calls, a lot of cold emails. And I get it. Like, you're going to reach 100 positions and hope that one responds. Like, I totally get it. It's a numbers game. But I think that there's a respect factor, like not calling us by our title, by like responding, like, for example, I've seen many posts like this where it'll be like, hey, we have a position for you. And the person write back and say, hey, my hourly rate, I am interested in this, but my hourly rate would be X, Y, and Z. And it doesn't really matter what that recruiter thinks about it. That's just what their hourly rate is, right? And that recruiter will write back like, that's ridiculous, or, that's above the market value. And it's like, well, yeah, but I have the belief that I'm that good of a product, right? And that's fine, So I think it's like that respect issue. And so I think it's just really great and refreshing to hear that you'll turn down opportunities, because it's not about the money. It's about, there is a bottom line, but it is about understanding and not upholding discriminatory practices, and just being able to like see through it. And you see tons of different opportunities. So your BS meter is probably really high.
Yeah, we take pride in our providers that we place inside an organization, because even though you're joining that organization, to us, you're really joining that community. And so if we are supporting a group that is discriminatory in any way, that's a reflection of us. We put that provider in that community that's not just going to touch one or two individuals. They're touching thousands. And so we want to be sure whoever we put in your community that we are able to stand behind that provider, and we're confident in our decision.
Yeah. And I think another thing that comes up, and this is sparked from a question by Anahid. I'm sorry if I'm saying that incorrectly, but I think that a lot of women, they hide their pregnancies, especially if they're looking for a new job. So say women here are pregnant or they have a newborn, they may hide that and just not disclose that because they don't want to be given a contract that's inferior to what they would have if they weren't in that situation, or if they were a man, So, and what's really frustrating is that there's this big taboo of not allowing, there's like lack of transparency. Like there's lack of transparency on many levels, but even to the level that they scare us that we can't share, our salaries with other people in our own positions. So I guess, can you guys all talk briefly about like what is the policy at your institution about, the pay gap, and discussing, and what happens if a woman finds out that she's getting paid less than a man? Like, what happens?
So I was thinking about that when you two were just discussing pay equity, and I made a note. I negotiate with hundreds of physicians a year, both men and women, and hands down, men always ask for more. And most of the time, not all of the time, women will either say, yes, I will take it, thank you. Or they will say, no, I don't want it. No, thank you. And it is less frequent that a woman, says, can you give me more in my base? Can you give me a sign-on? Can you give me this? Like, I've heard that the market is set this way. We have a standard compensation model. There's not a ton of flexibility on the first job coming in, but I think women need to ask more, right? They need to advocate for themselves more, and they need to ask more, because I will, if I know I have a man and a woman and I just gave a man a sign-on bonus, I'll go back and I'll give the woman the sign-on bonus too, even if she didn't ask for it, because I know she's not going to. But ladies need to they need to do that. And my girls came home one day and they were like, Mommy, did you know that women make less money than men? And I was like, yes, I do. And we need to fix that. We need to ask for it. And the organizations that we're working for need to be okay with it. And I think, I can tell you at Northwell, there's 2 women that do all the hiring for the health system. I oversee physician recruitment. My partner who oversees talent is a woman also. And we're big advocates for this. But women need to ask. So all of you, ask for someone.
Well, I think the question is like, how do we know what to ask for? First, before I move forward, I want to say that what sparked this entire idea of a virtual career fair where I ask these hard-hitting questions was, you know, a discussion with one of the lawyers that we partner with at Resolve Physician Agency, who they do thousands of physician contracts and they keep a database because MGMA, right? MGMA, right? That's what it's called. Okay, sorry, I'm not in academia, so like some of these things I don't deal with in practice. But MGMA, and all of the other tools are, I mean, even though they leak, but they're closed door, right? And so sometimes like people don't even know what to ask for, or if I compare it, you know, it depends on the region, right? And so I think that we're doing a lot of underground discussion, right, of what we get paid for, so we can tell each other what to ask for. And so we work with a physician agency that actually keeps all of that data, so they can help exactly do what you do, Judith, is they can go, hey, male Dr. Smith, you know, got a 60,000 sign-on bonus, you know, just 6 ago, kind of almost like comps of real estate, you know, just like, hey, like what's in the region, right? Or first of all, you have this other, you know, system of down the street and what they're doing, you know, so can you match that? So besides that, of using a contract lawyer, like what, if you guys can each name one thing that is very, like it's basically under asked, like if you can name one thing just to give these women some ideas of things that they should be asking for. So
I'll give you 2 things.
Leah?
First thing, never hesitate to reach out to me or anyone within my organization. We push out an incentive review on an annual basis that will show the salaries across the board, combining MGMA as well as MZ data and a ton of other providers that push out information annually, so you can see what is happening in each region. But even if you want to dig in, I'm always happy to dig in with you and supply you with the information. But to answer your first question of what's the one thing, so contracts are typically split up. You'll have your evergreen contract where that's what they pay and there's minimal negotiation. And then there's room for negotiation. So I think to Judith's point, asking on the front end, is this something that can be negotiated? And then once you get the confirmation, seek the education. Reach out to a group such as Merritt Hawkins, and we are always happy to supply you with the data that we have to show you what the comp data points are for the area that you're seeking.
That's really, so even if they don't find the job through you, or is it only if they find the job through you? Because I don't want everyone like flooding your email.
We are a full-rounded resource, and I'm a resource to y'all because I'm a mom to be as well. So I never want any of you to hesitate to reach out to me. The data's out there. We publish our white papers for the public, so it takes nothing for me to forward that information to you, or at least get you in contact with one of my employees that can.
I love that. Dr. Thompson, what do you think? What's the one thing? And I just want to thank you, Leah, for offering that as a resource, because a lot of us feel like we're a fish out of water sometimes. So thank you so much for giving us that. And Dr. Thompson, what do you think that women under ask?
So I think that the one thing that's really important to ask for, I mean, we've been talking about salaries and you know, the contracts, but I'm going to talk a little bit different about support for the work you need to do and the support for the work that you're passionate about. I think often as women, we do a lot of the things we're passionate about on our free time. We fit it in, we learn how to be superwoman. And I think it's important to find an organization that supports the work and understands that being a physician is much more than just being in an office and prescribing medications. So I'll give 2 brief examples. You mentioned my hypertension clinic for African-American communities. I looked at the data, I saw the disparities, and I knew that this is something we needed to do. We needed to lead, we needed to provide culturally humble, culturally responsive care. And I asked, and I was given support to help that. I could not have done that on my own. And that is something above and beyond what you might find in my contract. A second example is I'm very passionate about pipeline work and getting our youth and our community from underserved communities exposed to healthcare careers. And I believe as a physician, that is a part of my job. It's not prescribing medicine, but it is going to eliminate health disparities. And so that's another thing that I asked. I think as an organization, we should be doing this work, and I was given support to do that work. So I encourage women, if you're passionate about something, you know, Leah talked about data. When you have data and you see a disparity, we all should be focusing on equity for all. And so ask for support to do this work.
Oh my gosh, so powerful. Like I totally seriously have chills. I love it.
Amazing.
And Judith, what do you think?
So these are some details that impact your day-to-day life? And I feel like women sometimes hesitate to ask. So I'm going to run through just a few. Making sure you understand what the schedule is and whether or not there's flexibility. So I'll go back to I want to work 5 days a week and I'm going to work 9 to 5, or I want to work 4 days a week and I'm going to work 10-hour days, or I want to work 3 days a week, et cetera, et cetera. Is there flexibility, and how do you feel about that if I want to do some sort of different shift? What is the staffing in the office? So women sometimes hesitate to ask if they're going to have an MA or an NP or the staff that they need to be successful, and then they take on all of it on their own. So ask those questions, like understand what the staffing support is in the office, because that's going to impact the amount of work that you personally need to do. Ask why the position is available. So is this a position that's being backfilled? Did somebody leave, and did they leave because there's a problem, or did they leave because they're retiring and like there's a windfall of patients that are going to end up in your lap? Because if you're going to be compensated with some sort of net collections RVU upside, you want to know if you're walking into a book of business or you're walking into an opportunity to grow your own. And then understand what resources are available to you to help you grow that business. So if it is a new area where a system is expanding, what is that system? I'm sorry, I keep saying system because I come from a health system, but what do we have that's going to help you to establish yourself in the community and to connect with other physicians or community centers and establish referrals? Because you want to know that you're getting the support you need, and all of that will filter into your success.
Yeah, that's amazing. These are really good tips. And I think someone else brought up another good point, and I just want to make sure is, when we're talking about parents, I think that there's a difference in a parent that has, they're co-parenting with somebody else, or they're married, and then that person is possibly bringing in income. Not everybody is. Some people have stay-at-home husbands and wives, right? But then you have, a population of single parents as well, right? And so are there certain asks that they can have or benefits? I mean, what she had written here is actually so true. It's like, not even having any help with childcare as far as incentives, money, flexibility, whatever it may be, because they don't have another person to rely on. I mean, they could hire that person, right? But and everybody has different family situations. So what can they ask for? What kind of situations you have set up at your institution that's protective of the single parents?
So Leah made a good point I see in the comments about asking the organizations if they have a PDF of the benefits. We have the 50-page version, which I'm happy to give anyone who wants to read it. And then I have the 2-page version, which is condensed, and I can talk through it more quickly. We encourage people to use flexible spending and dependent care spending. We also have something called PayFlex, which is like a bucket of money that's put aside for them to help with, days when they need care for their children, and for whatever reason, their primary method just, hasn't worked out. And that's a benefit that the health system provides. I think understanding the benefits of the organization upfront is something people should always feel comfortable asking. And let me tell you something, men ask all the time. Women are always hesitant. Women are like always scared to ask about our FMLA policies, and they should ask. They should just know. One of the greatest things, and I sometimes don't know how to bring it up, but Northwell offers 3 rounds of IVF as a covered benefit. It's definitely something that's attractive that I think brings some women to us, and some women have told us confidentially after they've joined that was one of the things that was most attractive, and it's like whispered, behind closed doors. But it's something that they should, feel comfortable asking about, and I feel very happy to share.
That's really amazing. I wish I worked for Northwell.
Right? That's 3 babies.
I can add to that. So, and I think I've also responded in one of the comments, but to my point earlier, I think the key thing is really that education. Never hesitate to ask for the benefits package. and you're never asking too soon. So similar to Northwell, most organizations will have like a 1 and a 2 pager, and then they're 85 pager, right? But the 1-2 pager, you can easily read through it, and feel free to poke holes. Feel free to definitely compare and contrast that to the other positions and even your current position. A lot of times, depending on the type of benefit you're seeking, unfortunately, it's if we do it for you, we do it for the whole organization. So it's hard for them to typically add a benefit. However, I think the key thing is making sure that you're aware of what benefits you have. So in our screening process, similar to some of the discrimination questions that we may ask, we request the benefits up front, and we ask a lot of the questions that Judith mentioned. So why are you seeking a change? What was the most recent provider that you hired? Because that's sometimes important to know, like how outdated could you be? And then what was the most recent employee that you hired? So we typically go through a pretty in-depth vetting process, but never hesitate to ask.
Yeah, and I think these are really good tips. And I want Judith did it. Leah and Dr. Thompson, if you guys want to put your emails down, no pressure, so that way they can reach out to you, because I know that we're going to run out of time here. And so I just want to make sure that if they have specific questions to their situation, that they can ask you guys as it refers to your institution and recruiting practices. We have 2 other scenarios that Dr. Jane Doe unfortunately finds herself in. So I think what we're going to do is this. We're going to quickly go through one, and each person take one question. And then the other one, if this is okay, maybe we can have you guys answer by send it out to everybody that registered. No pressure, but if you want to, or maybe a video, you guys can tape yourself saying it, and then we can send it out. So, okay, the second question is really important. They all are important, but Dr. Jane Doe is a new physician at your institution, and she's been reported to HR by nursing staff and consulting physicians for many things, but basically they just don't like her. They say that her tone that she speaks with isn't part of the hospital culture. They feel that the physician feels that this is strongly due to racism, as she is a Black surgeon and her male colleagues and white female colleagues are not scrutinized in the same detail that she is. So for example, nurses are challenging her orders, whether they're appropriate or not for the patients, inappropriately escalating concerns as incident reports. They're reporting her to the peer review. I mean, these are things that we see over and over and over again, especially in our BIPOC community. She constantly faces comments filled with microaggressions that are rooted in discrimination, but they're disguised as personality differences, but they're really due to her gender, race, and age. For example, and this is a real example that was given in the group, there was a surgeon that said that a scrub tech made a comment once in the OR that said, "I can't believe that you've gotten this far at your age, and I'm just a tech. What have I done wrong?" And she was a Black surgeon. This is a very common scenario for our BIPOC physicians. While every institution seems to be focusing on diversity and inclusion, bringing up these concerns are often ignored and chalked up to individual personal differences. However, the color of skin and ethnicity of a person isn't a personal difference. So even in one case, this was one I was personally involved with a PA that was a Black woman PA. My medical director advised that I help her be nicer to win over the nurses, and suggested that I suggest to her that she bring donuts as a solution to racism and microaggression. So, which is ridiculous. So that's my thought. Anyways, when microaggressions are addressed at your institution, how was it filed and what happens? Let's go with Dr. Thompson first, and then I'll circle back around and we'll do the other 2 questions to you guys. And we have 7 minutes.
Okay, so I think, the answer is a complex one. And we all know that historically in medicine, speaking up is not the culture for most organizations. So we just start there. I think that our organization is aware, and I think taking a look inward and saying, are we doing things the way they've always been done because that's just what we do? Or can we look inside and see how we can make changes that make our culture psychologically safe, and that encourage a culture of speaking up and feeling safe and feeling supported when these things happen? So that's the first thing I'll say. I think, we have current formal ways of reporting these type of things through compliance and risk and HR, but there are also informal ways, and sometimes that leads to kind of minority tax type situations for some people. You go to the people you feel comfortable going to. But I will say in our organization, we have a leadership that's really physician led. And so many of our colleagues are the leaders and have open doors. And so you can go to people, but the problems come when maybe that person was involved in what people call microaggressions, which often are macroaggressions. And so I think we're really looking towards how do we make these reporting anonymous, that they're always taken seriously, that they're always feel supported, and that we can identify any patterns that may be going on and make sure that there's always psychological safety.
Thank you for your honesty. And yeah, there are no such things as microaggressions, really. So thank you so much for bringing that up. So how about Judith? Judith, can you take, what are the physicians' options at your institution to escalate if leadership or the HR representative are minimizing the concerns, thinking these are just microaggressions, I say in air quotes, or they're not that serious?
Yeah, so I think, similar to what Dr. Thompson said, there's a number of paths that you can pursue. And I think as Northwell continues to expand, we have a committee led by Dr. Jennifer Meares that I sit on, and it's she's our Chief of Diversity and Inclusion. She's also our Senior Vice President for the Center for Equity and Care. She's the Associate Dean of our medical school. She is just an incredible leader. And so she chairs a physician-led diversity and inclusion committee. We report out monthly on what changes we need to make in the organization, what we're seeing. Each service line is represented and they're, held accountable. So last month I reported out on what we're doing around D&I and physician recruitment, but it's a collaborative effort and we're all focusing on it. The other thing that I think helps, and again, this is over time. I've been at Northwell for almost 15 years, and our Chief Medical Officer is now Jill Kallman. Right? When our Chief Medical Officer for the whole health system became a woman, when they hired her, we were all celebrating. Our CFO is a woman. So it just, those kinds of changes, to see women and, women of different races in positions of leadership within an organization, I think makes you feel like you have someone that you can go to. It's harder when the C-suite all looks the same and is never going out on maternity leave. And so when Northwell over the last 15 years has changed, and I have a list of 1 million women that I can go to, I think it makes all of us feel more empowered. More of our chairs are women. More of our, executive vice presidents are women. We have more people that we can tap into.
Yeah, I think that leads really nicely into our third question. I'm going to give this to Leah. Leah, I think there's a lot of people who are looking. I mean, there's people here that are looking not only for clinical jobs, but ones that, do have leadership, roles with it. And there are a lot of women who are really interested in entering into the DEI space. So when you're doing recruiting, how do you help screen like the appropriate people? Because there are people who love to be in the DEI space who are not very empowering. It's very much like a resume builder for them, and they're not I'm trying to really choose my words very wisely here, but they want to be in the space to say that they're in the space, but they don't really have the requirements. So I guess my question is what are the requirements that you look for any leadership role, specifically DEI, for all of those that might be interested or know somebody who would be perfect for that job?
So I would say within the past 2 years, we've drastically seen a change with this. I'm sure with a lot of the social injustice, it's also added into what some organizations are doing and how they look at this a little bit differently. But I would say that we do our thorough vetting, and typically we get questions from the groups on what they would like for us to ask. As you can imagine, when we start looking at DE&I, the questions that you address start to get pretty legal, pretty tricky. How you ask it, what you ask, it's a different world. So typically for your leadership positions, you'll be completing an external survey of some sort to see your cultural sensitivity and confirm that you are even the right fit for the role. However, I would say as a recruiter and even organizations that have internal recruiters, it's very easy for us to tell when you're looking at it as a resume builder versus if you're passionate about something. And similar to what I shared earlier, we're looking at putting people within a community, not just within a job. And so we want those folks that are going to be passionate. There might be some that slip through the cracks. We can't detect it all, but I take pride in making sure that my recruiters try to, and we educate the clients as well that they need to as well. So if there is external surveys or someone that specializes in DE&I that they can speak to, that needs to be a part of the interview panel if that's something they're looking at doing.
That's really good.
This work, because I think it's really, really important. And we have a very active, we call it EID, equity, inclusion, diversity, because the diversity is here, but we want to make sure that we're striving towards equity. But I think it's really, really important to, again, recognize that people on these types of committees are not doing this in extra unsupported time, and that these type of imperatives need to be from the top of your organization down. There needs to be commitment shown. And so I'm really grateful to work for an organization where from the top of the organization down, we have structures and leadership in place at each medical center. And then it goes down the EID committee. We have various subcommittees. And this work really has to represent the voice of the people in our communities and our people who work here. And so I just want to, encourage people, if you're doing this work is a part of healthcare. With all the social injustices we've seen for centuries in this country, but most people are talking about for the last couple of years, that is affecting people's health, and listening to your people about how that is affecting them and how that is affecting the way they care for people is a part of healthcare. And so in our EID committee, not only are we looking at discrimination, but we're thinking about things like dialogue circles and how our people are doing. We're looking at representing the voice and perspective of our people. We're looking at being involved in our community as faces that look like the people we serve. So I just encourage you to remember, I would agree, it is very clear if someone's trying to build their resume, and it's very clear when someone is not. And so if you are doing this work, this is a place to ask for support from your organization and to challenge your organization to recognize this as a part of the job we do. And I'm really grateful to work for an organization that does that.
I love that you guys have reprioritized into EID, because I love that so much. And I may adopt that, and I will credit you and Kaiser for all of that, because I think it's so important. So I think this is a topic that could take hours and days to talk about, and it should have that time. And I feel bad that we only have 45 minutes in this panel. So, and the third question, which we're not going to get to, but you guys will get their answers, is about leadership and how a lot of women, despite what their ethnicity or any other background, oftentimes we're thought to have too much on our plate. And so we don't have the capacity or the availability to have leadership roles. So what I'm going to do is I'm going to have Dr. Thompson, Judith, and Leah, all three of you guys either type out your answers or do a video, like a short video, and we'll send them out to everybody who registered for this event, so you guys can get that, because I think it's really important. These are probably the most highest yield scenarios that I see on PMG, and I want you guys to be able to address them. And these are just 3 of the 20 plus employers that are here today. These are the 3 that stepped up and rose their hand first, although all 23 or plus did. But they're the first 3 that were like, no, we want to be at that discussion table. So they're here. So I want you guys to take the time to get to know them. They're going to be in their rooms, right? You guys have your rooms that you're going to be in? Okay. So each employer has a room or a booth. Okay. So you can go back and talk to Dr. Thompson, to Judith, Leah. You could go talk to all of them. And then you could also go see the other booths that are out there. Please go visit all of them. Give them all love. Ask hard questions. You're just in a screen. There's no intimidation factor. And I want to hear, what you guys find. So any closing remarks from the 3 of you?
Ask, and never shy away from getting the education you need, so that way you can advance your own career. And the education is there. I'm happy to supply it to anyone that's interested.
Yeah, everybody get all of Leah's white papers, all of them. And the compensation packages from both Dr. Thompson and Judith too.
I would just say that as physician moms, we really are superheroes. And just remember to take your cape off sometime and take care of yourself and ask for the support you need.
I love that.
That's so true. I think that's so true. We have to take care of ourselves as well, right? You know, I look forward to talking with all of you. Thank you so much for organizing this. Happy Women's Physicians Day, and definitely ask for whatever you think you deserve. Don't be shy. You probably do deserve it.
We definitely deserve a lot more than we're probably asking for. So this is what we're going to coach each other on. And I look forward to seeing all of you guys in the rooms. Thank you so much for being here. So this room's going to shut, and then you're going to have all of these other opportunities for other rooms. Okay. Please at least join 5-10 rooms, get to know the people, find out what they have, what their compensation packages are, and size them up and see what you find. All right. Talk to you guys later.
Thank you.